Hello and very welcome to everyone. I am Dr. Sudhir Mukherjee, an interventional cardiologist, and today I'll be talking about basics of cardiac ultrasound or echocardiogram. So, what is echo? Echo is something you experience all the time. We are very familiar with echo. If you shout into a well, the echo comes back a moment later. And the echo occurs because some of the sound waves in your shout reflect off a surface, either the water at the bottom of the well or the wall on the far side, and travel back to ears. A similar principle actually applied in cardiac ultrasound. And this echocardiogram has now become one of the most important diagnostic tool in cardiovascular examinations because most of the time it can diagnose a lot of disease structure wise, functional wise, and can help to guide the treatment approach. So a little bit of history regarding echocardiogram. In 1842, Christian Doppler first noticed the variability of sound wave with the changes of the source distance, and this ability ultimately created the ultrasonic wave and the ultimate relation of establishing in a very important role of echocardiogram. The ability to create this ultrasonic wave came in 1880 with the discovery of piezoelectricity by Curie and Curie. And Dr. Helmont of Sweden in 1953 obtained a commercial ultrasonoscope which was being used for non-destructive testing. He then collaborated with Dr. Edler, who was practicing as a cardiologist in Sweden. The two of them began to use this commercial ultrasonoscope to examine the heart. And this collaboration is commonly accepted as the beginning of clinical echocardiography as we know it today. So how the cardiac ultrasound actually uses the principle of sound waves. So echocardiogram is a type of ultrasound that uses a high-pitched sound wave to produce an image of the heart. You can see two images in the right side, which are basically transducer or probe. Is comprised of a crystal, a piezoelectric crystal that is situated in the foremost portion and which emits the sound beam, and it traverses through the body parts and ultimately getting reflected and again captured by the same transducer, and this is ultimately converted to a processor to the live image or the real-time image. And this is how the echocardiogram is practically recorded as a principle wise. So ultrasound gel is applied, and this gel actually helps to transmission of the sound waves from the transducer to the skin. The transducer transforms the echo, the mechanical energy, into an electrical signal which is processed and displayed as an image on the screen. And the conversion of sound to electrical energy is called the piezoelectric effect. And the cardiac ultrasound basic theme is about this piezoelectric effect. So this is how the principle of image generation and image generation in M mode and 2D. You can see the piezoelectric elements which emits the sound waves, and it is getting reflected from the various body parts, ultimately processed and scanned, and we can see various images in various mode, in the 2D mode and in M mode and other color doppler mode. So basically we call it a grayscale image. As you can see, this is how it looks like in the right side of the screen. So grayscale image is generated based on intensity of reflected echo. The black color is fluid or blood, and the white is calcification on cardiac valves or pericardium, and gray is your normal myocardium. So this is the machines of echocardiogram. We have all seen it in echo room, echo lab, or in OT. So there are 5 basic components of ultrasound scanner that are required for generation, display, and storage of the ultrasound image. First is pulse generator that applies high amplitude voltage to energize the crystals. Second is your probe or transducer that converts the electrical energy to mechanical energy, and vice versa. Receiver detects and amplifies the weak signals. Display, that is displaying the ultrasound signals in a variety of modes, and ultimately we can see the images in the live term or the live form. So coming to the transducer is responsible for both the emitting as well as capturing the reflected wave. It consists of electrode and a piezoelectric crystal whose ionic structure results in deformation of shape when exposed to an electric current. The PE crystals are composed of synthetic materials such as barium titanate, which when exposed to electric current from the electrodes alternately expand and contract to create a sound waves. When subjected to the mechanical energy of sound from returning surface, the same P element change the shape, thereby generating an electrical signal detected by the electrodes. Coming to now the indication of 2D echo, it can be divided grossly in the structural and the hemodynamic points. Within the structural imaging, we can diagnose so many structural disease starting from pericardial, that is pericardial effusion, ventricular, cavity, left ventricle, right ventricular hypertrophy, and any other valve motion abnormalities, images of the valve, stenosis or prolapse, great vessels, including the aortic dissections, congenital and traumatic heart disease, and also the other effects of hypertension, suspected ischemic heart disease, and several other pulmonary disease, including some of the arrhythmic disorders. Within the hemodynamic images, we can assess the blood flow through heart valves, the stenosis or regurgitation, its severity, blood flow through cardiac chambers, systolic and diastolic functions. There are several types of echocardiogram. Normally, the standard one is called the transthoracic echo that we can do as per chest. There are several windows of doing transthoracic echo. I'll come to it later. There are several other types of echocardiogram that includes transesophageal echo, we do from the esophagus, and intracardiac imaging. So basics and physics of this basic echocardiogram is that whenever we place the probe or transducer, the sound waves are emitting and gets reflected and captured and ultimately processed, and we can see the real-time images. The difference in TE and intracardiac imaging is that they use the higher frequency sound waves to generate high resolution images. And in that cases, the waves do not travel far. This is the basics of physiology, but allows for imaging of the finer details. Transesophageal echocardiogram uses frequency of 7 megahertz usually, and intracardiac a little bit higher, approximately 5 to 10 megahertz. TT, that is just normally standard we see in the echo room, is that lower frequency sound waves are used to generate high resolution images, and this resolution is comparatively lower compared to TE, transesophageal echo, or intracardiac imaging. And but one of the important aspects of TT is that it allows for deeper penetration of waves through more tissue, adequate for most situations. So it is the most commonly used echocardiography technique for diagnosing most of the disease in cardiovascular spectrum. And transthoracic echocardiogram uses frequency of 3 megahertz. That also depends in various scenarios, but most of the time this is the average 3 to 4.5 megahertz. So this is how the echocardiogram is done. The patient lies in the left lateral, sometimes supine posture, and the right-handed operator usually sits besides and can place the probe in different positions in different window, and we can see the real-time images of cardiac activity. So these are the standard positions on the chest wall that are used for examining the cardiovascular system during echocardiogram, and you can easily diagnose this thing. One is suprasternal window, that is above the sternal. Then it is left parasternal, apical window, and subcostal window. Apart from that, there are several other windows. These are the most commonly used windows. The parasternal window, long axis and short axis. Then apical window from the apical portion of the heart. Then subcostal window and suprasternal window. So what we see in parasternal long axis view, this looks like from the parasternal view. If we take the section from the parasternal view, then we usually see these structures. These are basically on the left ventricle, septum, little bit of right ventricle, at the same time left atrium, aortic valve, mitral valve, and their leaflets along with papillary muscles, overall movement, and of course any valvular abnormality. The transducer position is the left sternal edge, second to fourth intercostal space. Marker dot direction point towards right shoulder. Most echo studies begin with this view. It sets the stage for subsequent echo. This is the parasternal long axis view, and in the right side of the images you can see the structures. This is LVOT, RVOT, mitral valve, aortic valve, and inferior valve. So this is how it looks like in parasternal long axis view. You can see the pointer is directing towards right shoulder. This is very important because if you change, then it will be inverted. So parasternal long axis view is very much important for diagnosis of several disorders that it usually off from right ventricle, left ventricle, aorta, ascending aorta basically, aortic valve, mitral valve, pericardium. So different types of disorders can be diagnosed from this, and this is one of the most important view. And this is how it looks like, as you can see easily here. So These are the structures that has been identified in the right side of the screen. One is a pericardial space, two is a right ventricle, three is the septum, four is left ventricle, then anterior leaflets, apical root, and LX. So you'll get accustomed to it much more you spend time in it. So this is how a parasternal long axis view looks like. Here you can see the mitral valve, the posterior leaflets a little bit whitish, and therefore its calcification. So these are the disorders that can be easily diagnosed in parasternal long axis view. Now coming to short axis view or PSAX, parasternal same position, but the marker dot direction point towards left shoulder, that is 90-degree clockwise from the plex view. So by tilting the transducer on an axis between the left hip and right shoulder, short axis view can be obtained, and this is one of the most important view because you can do the short axis view in different level. You can examine in the apical level, you can examine the papillary muscle level, you can examine in the mitral valve level and at the basal level. And you can see a lot of structures starting from apical to basal level. In most of the short axis, we usually look into the aortic valve, its cusp, and sometimes coronary arteries. Also the pulmonary valve, the pulmonary branches, the RVOT, as well as the tricuspid valve. In the mitral valve level, we usually examine the opening and the closure of mitral valve if there is any stenosis or any regurgitation. In the papillary muscle level, we examine the papillary muscle, is there any abnormalities and overall wall motion abnormalities of the left ventricle as such. So this is how the parasternal short axis is actually looks into the heart. The rounded structure is the left ventricle, and this right sided structure is the right ventricle. You can see the mitral valve leaflets, enteromitral leaflets, as well as posterior leaflets, and the papillary and apical level, we can also examine some of the septum as well as the overall left ventricular wall. So this is how the parasternal short axis view. The important point is being that the pointer is directing towards the left shoulder. Coming to papillary muscle, this is very important. The P6 at the level of papillary muscle showing how the respective LV segments are identified. There are 17 segments nowadays altogether as designated by the American Society of Echocardiography and has been adopted by worldwide all the Echocardiography Federation, including European Society and of course our Indian Society. And these 17 segments of these LV is very much important to assess the particularly wall motion abnormalities and overall other aspects of ischemia. That is a very important aspects of echocardiography examination whenever you are looking into the patients who are suffering from ischemic heart disease. Coming to apical fourth chamber B, this is how we placed in the apical portion. You can see the pointer position is downwards, so point towards the basically downwards so that we can see. And this is how the apical chamber actually look like. In the left side it is LA and LV, in the right side it is RA and RV. And we can see the septum as well as any other valvular regurgitation or stenosis and overall movements of the heart. So this is one of the most important position, that is the apical fourth chamber view. An apical fourth chamber view easily can diagnose a lot of disease, including mitral valve pathology, tricuspid valve pathology, overall LV movements, left atrial movement, any interatrial septum abnormalities like this. An apical fourth chamber view is in the normal subject, it looks like this. So this is the apical view. You can easily diagnose by the fourth chamber view. And these are the structures, and also you can easily diagnose the apical chamber. And now coming to a little bit modified from apical fourth chamber is apical five chamber view, where we can see also the aorta as well as the LVOT along with the four chambers in the apical fourth chamber. And this view is obtained from this view by slight anterior angulation of the transducer towards the chest wall. The LVOT is one of the important aspects in the apical five chamber view, and in several disorders we can see a lot of abnormalities in LVOT. You can see the pointer, and this is how apical five chamber looks like. This is aorta and the LVOT along with the fourth chamber. Now coming to apical two chamber view, this is again modified from the apical fourth chamber. The marker dot direction is point towards left side of the neck, that is 45-degree anti-clockwise from the apical fourth chamber, and this is very good for assessment of LV anterior wall as well as LV inferior wall. So this is how the apical two chamber view actually looks like, LV and both the wall of the LV. And this is exactly the diagrammatic representation of the apical two chamber view. We can diagnose the apex, the inferior wall, the mitral valve, and sometimes coronary sinus. Coming to subcostal view, this is one of the most important aspects of examining echocardiography, especially when we are examining a pediatric population and patients who are suffering from atrial septal defect, to look into the septum because it's directly examine the septum in a 90-degree direction. The transducer position is under the diphisternum, marker dot position, point towards left shoulder. The subject lies supine with head slightly low, no pillow, with feet on the bed. The knees are slightly elevated. And Baton images are obtained with the abdomen relaxed and during inspiration. Interarterial septum, pericardial effusion, and descending abdominal aorta can be examined. This is how the subcostal examination is done. And these are the chambers that you can usually see, the LA, then the interarterial septum, which is perpendicular to the transducer. We can also look into the tricuspid valve, the RV, and the pericardial space. So this window is one of the most important window in cases where we are suspecting atrial septal defect and in cases of pericardial effusion. Coming to suprasternal view, where the transducer is positioned in the suprasternal notch, marker dot direction towards left jaw. The subject lies supine with the neck hyperextended. The head is rotated slightly towards the left. The position of arms or legs and the phase of respiration have no bearing in this window, and basically we look into the arch of aorta and its different branches. This is how the suprasternal window looks like, and its several branches. This is very difficult in an adult population. However, this is one of the most important in cases of where we are suspecting different types of aortic disorders, including coarctation of aorta. So the modalities of echo, basically the conventional echo, the two-dimensional echo, a mode echo, and also we do use the Doppler echo, including color flow. The two-dimensional echo is basically the techniques we use to see in different modes, different views, different windows, in different kind of structural changes. And in the M mode, basically used for the measurements as well as giving overall assessment for the chamber enlargement or ejection fraction. And apart from that, we can also use the color flow to see the stenosis and regurgitation. And the Doppler mode, we can measure the gradient across the different valves. So these are the basics of the echocardiogram. The modes of display we can see in different modes that I will be showing you. So in the M mode, we can see the opening of the mitral valve, leaflets, as well as the movement of the LV, and we can measure several parameters of the LV like LV internal diameter, in systole, in diastole, overall LVEF, the thickness of the LV, thickness of the septum, a lot of things. And in the overall, the 2D mode, we can see overall structural changes. In the Doppler echocardiogram, we can use two types of, one is a pulse wave Doppler that is useful for low velocity flow, and one is continuous wave Doppler for high velocity flow. So these two Doppler examinations are done, two types of Doppler, and we can see the gradient across the valve in cases of stenosis. We can see the regurgitation, and this Doppler, and we along with the color mode, is very much useful in diagnosis of various valvular heart disease. Regarding color examination, one must know that the color will be red when the blood flow towards transducer, and it will be blue when it is away. So, and when there is turbulent, we can see the mosaic pattern. So this is very important aspects of examination during the regurgitation pathology. So blue away and red towards. These are the basic things whenever we are using the color mode. This is the pulse wave, how it looks like, and in the continuous wave, how it looks like in cases of regurgitation, in cases of overall valve, mitral valve pathology, or any other tricuspid valve pathology, or in cases of aortic stenosis. So the Doppler examination actually completes the overall echo examination, and this is how the echocardiogram from the transthoracic aspects is done. Regarding transesophageal echocardiogram, that is used to assess the posterior structures like left atrium and aorta. This is done by introducing the probe through esophagus. First, the close proximity to the esophagus to the posterior wall of the heart makes it very much useful for this examination. Therefore, it has been used in several disorders, especially in mitral stenosis, where we want to look into the left atrium, whether there is any clot or not, and in several aspects of cases of infective endocarditis to look for the vegetations, and also in cases of prosthetic valve disorders. And apart from that, during several procedures we do use during closure of several ASD, VSD like this, and along with there several other procedures nowadays. They are very latest and they are very innovative. We can use this intraoperative transesophageal echocardiogram. So this is the most important aspects of transesophageal echocardiogram. However, we must know that there are some conditions where it cannot be used, like any esophageal pathology. In cases of dysphagia, stricture, diverticula, esophageal varices, and cancer, this is absolutely no-no. And along with the cervical spine disorders are also related contraindication where we use for transesophageal echo. So, and ultimately the intracardiac echocardiogram, that is a very high resolution images in direct contact with the cardiac structure. And in that context, intravascular ultrasound we have been now using inside the coronary arteries also. That's a very high frequency sound waves that uses to see the athermatous plaque burden. So these are the various spectrum of the echocardiogram where we use echocardiography, the basic ultrasound waves to see various structures of echocardiogram, various structures of cardiac muscle, various structures in cardiac valves. Apart from that, we can also use in cases of stress echocardiography where we use either exercise or some pharmacological agents to look for the changes in the cardiac output, to look for the changes in the wall motion abnormality. These are a pretty advanced kind of echocardiography examination. So for the basic thing is concerned, we must know what are the machines, what are the instrument parts and how it is being recorded, what are the basics, window for examination and how it is being recorded. And with this, I would like to conclude this session by drawing some conclusion regarding echocardiogram basic codes that the echocardiography provides a substantial amount of structural and functional information about the heart. The still frames provides anatomical detail. Dynamic images tell us about physiological function. The quality of an echo is highly operator dependent and proportional to experience and skill. Therefore, the value of information derived depends heavily upon who has performed it, and that can only be obtained by spending more time in the echo lab. So this is how you learn the basics of echocardiogram. I hope this video lecture helps to understand the basics of echocardiogram, and in the near future you will be able to perform the echocardiography along with more knowledge with time goes by. So till then.